Dear viewers, in this video, I am going to talk about two different contrasting oxygen delivery devices, NIV or HFNC, which, when, and why. Mm, Often, these two devices are used interchangeably with the expectation and view that they would serve the same purpose of achieving mechanical ventilation with improvement in oxygenation and reduction of hypercapnia with in an identical manner. But it is very important to distinguish their modus operandi so that they can be appropriately used for the right indication in which their benefits can be accrued to the maximum. Let us start with a case. A 35-year-old male presents with fever, difficulty in breathing, and weakness and malaise for 2 days. Patient is conscious, alert, tachypneic, heart rate is on the upper side of the normal. The blood pressure is normal and saturation is 90% on room air. Chest X-ray shows bilateral non-homogeneous opacities, unequal, with right side showing more opacities than the left. The lung ultrasound shows multiple V lines. The ABG shows a pH of 7.36, PO2 of 60, PCO2 of 45, and bicarbonate of 28. Customarily, patient is treated with IV fluids, antibiotics, duolin and budecart nebulization, and oxygen is delivered by ventimask at 6 liters per minute. After 2 hours, upon review, the patient is found to have increased in the respiratory rate, tachypnea with a rate of 40 per minute. The saturation has fallen to 86% with 6 liters per minute of oxygen. The blood pressure is still normal and the heart rate has also showing tachycardia. Question is, how should we proceed? Should we continue with the same oxygen delivery device? Should we modify it? Or should we go for endotracheal intubation followed by invasive ventilation? When we should understand that whenever we are using the low flow oxygen devices like the ventimask or the nasal prongs, it is not able to reach the peak inspiratory flow of the patients with acute respiratory failure. Typical low flow systems provide supplemental oxygen directly to the airway at a flow of 8 liters per minute or 10 liters per minute. Now, this oxygen provided by the device is always diluted with ambient air because the peak inspiratory flow rate of such patients is much higher. Say it is around 30 to 40 liters per minute. And since it is diluted with ambient air, which has 21% of FiO2, the final result is a low and variable FiO2. Therefore, although our intention is to improve the air FiO2, thereby improving the oxygenation of the patient, but the same cannot be achieved. So at oxygen flow rates of up to 6 liters per minute, a patient breathes only 22 to 40% of the oxygen for low flow nasal cannulas or nasal prongs. And if it is with low flow masks, then they breathe only 35 to 50% of the oxygen flow at a flow rates of 5 to 10 liters per minute. Beyond that, it is not possible to improve the oxygenation. Hence, we need a device like high flow nasal cannula, where higher flow rates are able to meet or even exceed the patient's peak inspiratory flow rate so that the FiO2 is delivered more accurately and it can be maintained at the desired level of intent. In addition, when we use HFNC, the humidification also can be performed, and we know that humidification is recommended when O2 is supplied through a nasal cannula at flow rates of more than 4 liters per minute, which is otherwise not possible with ventimask or other low flow oxygen devices. Now, for both these reasons, in such a patient, it is good to start with an HFNC. Currently, if we look into the clinical applications of this device, we can see that there are a lot of conditions where it achieves the desired clinical effect. Like in acute hypoxemic respiratory failure, it reduces dyspnea, improves oxygenation, decreases escalation to invasive support, etc. In hypoxemic failure in immunocompromised patients, also it reduces dyspnea, improves oxygenation, reduces the intubation rate, and thereby prevents the complications associated with the invasiveness of mechanical ventilation. And although there is some doubt that whether it reduces or not, but still a good number of studies also points to a reduction in mortality in hypoxic failure in immunocompromised patients. Likewise, it also is beneficial in cardiogenic pulmonary edema, in exacerbation of COPD, although there are other points of consideration in this condition, which we'll discuss in the subsequent slides. In after extubation, in patients with high risk for extubation failure, where it improves gas exchange and decreases the reintubation rates, and in also while performing procedures in the respiratory tract, where it improves oxygenation during the endoscopy or other procedures. But we have to remember that the main physiologic effects on which it accrues benefit is also compensated to some extent by the increase in the airway pressure and end expiratory lung volume. But this increase in airway pressure and end expiratory lung volume in a way improves the physiology by generating PEEP, and these improvements in oxygenation are more evident as we reach the higher flows of around 60 to 70 liters per minute. They're not so much evident when HFNC is used at lower flow rates. So there are some conditions where it is strongly recommended, like hypoxemic respiratory failure, where there is clear benefit in terms of lowering the intubation rates, reduction in escalation of respiratory support, and cost savings in terms of equipment and intubations, which are avoided by avoiding invasive ventilation. There are some conditions where there are only conditional recommendations, like post-extubation and post-operative HFNC in high risk and or obese patients following cardiac or thoracic surgery. There also it can reduce or lower the intubation rates and reduce post-extubation respiratory failure, but it also has to be justified in the clinical context in patient with regard to the presence of other comorbidities or other risk factors. In peri-intubation period, there is no recommendation, but it has often been an off-label use of this device in patients who are already receiving high flow should continue to receive such high flow with HFNC during intubation. Now, what an important thing to consider is how to choose the right HFNC interface. We know that if the diameter is too big, it may cause obstruction of the nares. So in order to maintain an effective flush of the CO2, it is important that the nasal cannula does not occlude more than 50% of the nares. Because if we do that, many a times the CO2 may continue to rise even after HFNC. And although there is a bit of improvement in the oxygenation, but at the same time, there will be a rise in CO2, and it will be difficult for us to make out the cause of that increasing CO2. And also, if this diameter is more than 50%, it occupies more than 50% of the diameter of the nares, the airway pressure increases progressively, and with both increasing flow rate and with the nasal prong to the nares ratio. So how to adjust the HFNC settings? Initially, we set the flow between 20 to 35 liters per minute, and the flow can be progressively increased in steps of 5 to 10 liters per minute if the respiratory rate fails to improve. Increasing flows from 15 to 45 minutes triples the reduction in the anatomic dead space, because high HFNC clears out all the air which is trapped in the dead space, and thereby leading to a reduction in rebreathing of the expired gases. To prevent intubation, we have to choose the highest flow which is tolerated by the patient. FiO2 can be set between anywhere between 21% to 100%, and FiO2 should be titrated to achieve the desired SpO2. In most cases, the desired SpO2 is in the range of 92 to 96% for any average patient, and slightly lower with 88 to 92% in patients with chronic respiratory disease or COPD, because we know that there are only two drives to keep breathing. One is the hypoxic drive and the hypercapnic drive. And since these patients already have a hypercapnic drive, they are too much dependent on the hypoxic drive. And if we try to increase it beyond to 92, that is 96, 98, 99%, then it will reduce that hypoxic drive. So these are the ways we will have to adjust the settings. How can we determine whether there is the HFNC is successful or there is a failure? Now, ROX index has been traditionally validated and is found to provide useful clue to the success or failure of HFNC. ROX index is the ratio between the SpO2 by FiO2 to the respiratory rate. And if a ROX index is more than 4.88, it indicates success. Less than 3.85, one needs to consider intubation. And this ROX index can be used after HFNC to help identify such patients who are at high risk of intubation. It has to be always remembered that all the studies that we look for in these devices, whether it is conventional oxygen therapy versus HFNC, or conventional oxygen therapy versus NIV, or HFNC versus NIV, the studies primarily look into two things. One, whether there has been intubation, and number two, what is the mortality. So if there is no difference in intubation and there is only mortality, that points to some some fault in the strategy. If there is difference in rate of intubation and difference in the mortality, then that indicates failure of the device. So these two things we will have to clearly understand, that whether there is a failure in our strategy or it is a failure of the device, and that can be only looked upon while considering in conjunction the intubation and the mortality. We know that the lung safe study, one of the good studies which had shown that as the intubation increases, the mortality of this patient increases. So if the intubation does not increase, but still the mortality is different, then that is a fault in some of the strategy. So that is what was found in the Florali study, which compared conventional oxygen versus HFNC versus NIV, where it found mortality to be least with HFNC. Now, there are certain recommendations for measuring the ROX index. We will have to see that when we initiate at 2 hours, at 6 hours, and 12 hours, if the ROX index is less than 2.85, consider endotracheal intubation. More than 4.88, continue monitoring. Between the two, increase the support and reevaluate in 30 minutes, and to look for the change in the ROX index. So this is to be done 2 hours, 6 hours, 12 hours, and it is one of the good ways to monitor so that we do not delay intubation in case their HFNC fails. Now, when should one consider weaning from HFNC? We should suggest discontinuation or switching to the conventional oxygen if patients are stable with a respiratory rate of less than 25 and saturation of more than 92% at settings with a flow of 30 liters per minute and an FiO2 of 0.4. Because it has been seen in many studies, including in a retrospective analysis of 190 HFNC patients, that an FiO2 of less than equal to 0.4 and ROX of more than 9.2 were predictors of HFNC weaning success. Although it is difficult to achieve 9.2, but it can be followed in the chart which I showed in the previous slide, and the same can be successfully and conveniently used. However, the sequence of reducing the HFNC variable, that is whether flow or the FiO2, that remains to be investigated, because it is still not clear which should be reduced first and which should be reduced last. But the general consensus so far, based upon whatever we know, is leaning towards weaning FiO2 to 0.4, and only when the patient tolerates an FiO2 of 0.4, reducing the flow to 30 liters per minute. So, given its non-invasive nature, weaning from HFNC in adult patients is less much of a concern, because if after a reduction or weaning the patient again shows deterioration, it can be increased without any further invasion. But of course, we have to understand that if it is fails even after correction, then it is an indication for intubation. Let us see the second case. A 50-year-old male, a COPD patient for past 15 years, presents with fever, cough, wheezing, and respiratory distress for a day. Patient is anxious, agitated, tachypneic, with a heart rate on the upper side of the normal, blood pressure of 140/70, saturation of 90% on room air. Chest has prolonged auscultation of the chest shows prolonged expiration, wheeze, occasional creps, movement of the accessory muscles. ABG shows respiratory acidosis. Patient is nebulized with duolin Budecort, delivered oxygen by mask, antibiotics, fluids as a prudent approach to the condition. But after 2 hours, shows no improvement in the condition. The respiratory acidosis still persists. The saturation drops further to 85 to 88% on 6 liters per minute flow on ventimask. Now, how should we proceed further? Should we continue with the same device, or should we move on to some other device? Now, these are the patients with acute exacerbation of COPD where maximum benefit can be availed by using the non-invasive ventilation, by using the non-invasive mask. The established criteria for patient selection includes persistent acidosis, which was present in our patient, hypercapnia or tachypnea, despite optimal bronchodilator and conventional oxygen therapy. Now, ABC approach, which we follow, an acronym which reflects the three classes of drugs, antibiotics, bronchodilators, and corticosteroids, need to be used. The ventilatory support can lower the level of the respiratory muscles load because it can offload them by helping them do this work, and that can reduce dyspnea and the respiratory rate and improve the arterial oxygenation, bring down the PCO2 and improve the pH. In fact, the GOLD guidelines of 2024 advocate for NIV as the primary ventilation mode for addressing acute respiratory failure in hospitalized patients with acute COPD exacerbations. But we have to remember some absolute contraindications also, like cardiac or respiratory arrest, severe NCAF, severe GI bleed, severe hemodynamic instability, facial surgery or trauma, upper airway obstruction, inability to protect the airway or high risk of aspiration, inability to clear secretions, all are in contraindications and mandate invasive ventilation. Now, besides this, where else can we use NIV? NIV can be used in patients experiencing cardiogenic acute pulmonary edema because it has demonstrated significant benefits, including mortality reduction. When a patient has failed NIV, the decision is made to proceed with intubation, but NIV can continue to serve as a pre-oxygenation strategy, and this has been seen in the famous pre-oxy trial. So that is one use. Utilization of NIV can enhance pulmonary aeration and mitigate atelectasis in patients undergoing major abdominal surgery in the postoperative period. NIV is deemed effective to ameliorate dyspnea without causing discomfort in palliative care in end-of-life cancer patients, and also it can be used in immunocompromised patients with acute respiratory failure, where it can reduce the complications associated with invasive mechanical ventilation. Now, how to start NIV for COPD, taking COPD as a classical example for initiating the settings. So the mode should be pressure support, and there are certain variables which need adjustments periodically. We can start with an IPAP of 10 centimeter water and a EPAP or PEEP of 4 centimeter water. Rise time 1 is the shortest. Inspiratory trigger and the expiratory trigger can be 1 and 3 respectively. Minimum inspiratory time can be 0.4 and maximum can be 2. and the backup rate of 8 to 10. Now, the adjustments can be made according to the condition and to the response of the patient, plus 2 centimeter of water for every 2 minutes up to the maximum tolerated by patient in case of inspiratory pressure, and by plus 1 centimeter water if the difficulty is to trigger the breath in the patient. How to monitor the settings? We monitor the respiratory rate and the patient's comfort for the IPAP, patient's effort to trigger the ventilator, and synchronization or whether ineffective respiratory efforts are there to note the EPAP. For the rise time synchronization, if there is flow overshoot, we have to increase the rise time. For inspiratory trigger, it can be increased to by 1 as long as auto trigger is present. Patients we have to see that the patient's effort to trigger the ventilator is adequate, and synchronization should also exhibit ineffective inspiratory efforts or auto triggering. Then only we can increase the inspiratory trigger. If there is premature or late cycling for synchronization, then we can increase the expiratory trigger, or we can reduce also according to the level of the patient's comfort and like forth. However, there is slight difference in the British Thoracic Society guidelines. Of course, besides looking for the size for the face mask, which has the smallest mask that fits comfortably, permitting very small leaks, and positioning the patient in bed at 30 degrees centigrade. The other ventilator settings remaining same, the British Thoracic Guidelines recommended an expiratory trigger of 2 and an inspiration trigger of 2, in contrast to 1 and 3 by the American societies. Of course, the rise time is similar, and if oxygen is required, the meat should be set at 4 liters per minute and titrate in order to maintain saturated oxygen SpO2 of 88 to 92%. And increase IPAP in increments of 2 centimeter of water, which was to the maximum the patient can tolerate. Now, this is also similar to the US guidelines, so there is no difference, although it mentions to that the maximum that the patient can be tolerate, and keep on monitoring patient's respiratory rate and patient's comfort in the same way that the US guidelines recommend. Now, how to monitor the patients on NIV? We should record observations every 15 minutes for the first hour and thereafter evaluate hourly. The SpO2 monitoring through continuous SpO2 monitoring, ABGs, first hour post commencement of the NIV, thereafter evaluate as per patient's condition. But if ABGs worsen after 4 to 6 hours, then it is again a poor prognostic factor for NIV, and such patients should not be delayed intubation. We also monitor the respiratory heart rate, the use of accessory muscles of respiration, the chest wall movement to ensure adequate ventilation, and also see whether there is in sync with the patient's efforts and the ventilatory efforts, and how much is the air leak. But monitoring alone does not suffice to alter the patient outcomes, and the treatment of the primary cause of this is always more important than this pure monitoring and the ventilatory patterns. What are the features of failure with an IV? Hacker is a potentially useful bedside tool for prediction of NIV failure. As the acronym says, it includes the variables heart rate, acidosis, consciousness, oxygenation, and respiratory rate. It accurately predicts NIV failure in patients with hypoxemic respiratory failure, but it has also been validated in many places in hypercapnic respiratory failure. A Hacker score of more than 5 at 1 hour of NIV highlights patients with more than 80% risk of NIV failure, regardless of diagnosis, age, and disease severity. So whether we use SOFA or Apache or Curve 65, any of this, it is irrespective of this, we have to stick to that number of 5, the magic number. Now, if we look into 3 different settings of NIV use, acute decompensated heart failure, acute exacerbation of COPD, and acute hypoxemic failure, we can see certain differences in the parameters and their settings. In acute exacerbation of COPD, pressure support may need up to 10 to 18 centimeter of water with a CPAP of 5 centimeter. Target tidal volume on the slightly on the higher side of the predicted body weight, and keep the respiratory rate to less than 20 per minute. In acute decompensated heart failure, we can keep the pressure support, the CPAP to 5 to 15 centimeter, adjusted according to the patient's tidal volume. The FiO2 of 0.5 can be increased if the SpO2 remains below 94%. There is no need to increase if it is above 94. In acute hypoxemic respiratory failure, we begin CPAP at 10 centimeter, adjust to low tidal volume of less than 6 ml per kg body weight to reduce any risk of damage caused by ventilator-induced lung injury. Maintain the FiO2 on slightly higher side in comparison to the other two of 0.6, and then adjust it to achieve a SpO2 of target of 88 to 92. The desired effect in acute decompensated heart failure is to improve myocardial performance and respiratory mechanics both. In acute exacerbation of COPD is to offset the auto-PEEP, reduce the work of breathing and improve ventilation, while in acute hypoxemic respiratory failure, it is primarily aimed to improve the FARSI-VQ mismatch and reduce the respiratory effort. So when to decide on intubation at acute decompensated heart failure? If at 1 to 2 hours there is depressed mental status, respiratory fatigue, despite other things being normal, Hacker of more than 5, then we have to think about intubation. In case of acute exacerbation of COPD, if there is respiratory fatigue despite optimal near infrared spectroscopy, depressed mental status, severe respiratory acidosis, and Hacker more than 5, then that is an indication for intubation. While in acute hypoxemic respiratory failure, Hacker score is more important in comparison to the others subjective symptoms, and the patient should be intubated without further delay. Now, how to know if the patient is ready to be weaned from NIV? If the patient remains clinically stable for more than 6 hours, respiratory rate is less than 24, heart rate is less than 110, pH is more than 7.3, and SpO2 is more than 88% with 4 liters of oxygen while on NIV. So if the answer is no to the above, we have to continue NIV and monitor as before. If the answer is yes to the above, we allow breaks for meals, medications, physiotherapy, consider only nocturnal NIV or controlled oxygen therapy. But if worsening respiratory distress is noticed, we have to reassess the patient, review therapy, and consider recommencing NIV. If not, there are strong reasons for intubation. So when to discontinue NIV? After the resolution of the cause of the acute respiratory failure, some withdrawal criteria can be applied, and this includes adequate oxygenation. The US guidelines mentions PF of more than 200 during NIV with an FiO2 of 0.5, while the British guidelines maintain of FiO2 of 0.4, rest remains same. pH more than 7.35, RR, that is respiratory rate, than 25 without the use of accessory respiratory muscles, hemodynamic stability ensured, KD score of less than 2, and absence of respiratory distress signs like agitation, diaphoresis, or anxiety. So these are very clear indications or hard indications for discontinuation of non-invasive ventilation. Another criteria for NIV withdrawal is the presence of failure predictors, which may include high disease severity scores, whether it is Apache, SAPS, or SOFA, advanced age, lack of improvement post 1 hour with NIV, multi-organ involvement, premorbid state indicating self-care, lack of self-care ability like pH of less than 7.25, PCO2 of more than 75 after 2 hours of NIV initiation in hypercapnic acute respiratory failure, difficulty in identifying the ARF etiology, like whether it is because of ARDS or pneumonia or a little bit of both, and a PF ratio of less than 150 milliliter of mercury, we should not waste time. We have to consider intubation. Now, this study was published this year, a comparison of high flow nasal cannula versus non-invasive ventilation as initial treatment of acute hypoxia. And in this study, there was a comparison of the major pulmonary adverse events because patients receiving NIV versus HFNC in a matched cohort using a win ratio. So a win ratio is the ratio overall wins for NIV versus overall wins for HFNC. A positive win ratio suggests NIV results in better composite outcome compared with HFNC. So this is a composite outcome which was looked into, and in this case it was found that the win ratio favored the HFNC, favored the NIV over HFNC because it was 1.38. Another study which also was published this year in intensive care medicine was effectiveness of high flow nasal cannula versus NIV and conventional oxygen therapy in patients weaned from invasive mechanical ventilation. So this study findings a comparable efficacy in preventing reintubation within 48 hours of post-extubation. And there also NIV displayed some advantages over HFNC and conventional oxygen therapy in terms of lowering the intubation rates and also lowering the mortality rates. So my final take-home message is HFNC seems to be a good alternative to standard oxygen and NIV as a treatment for patients with hypoxemic respiratory failure. Its good tolerance, physiological effects including delivery of high FiO2, PEEP effect and dead space washout lead to decreased work of breathing and probably can avoid lung strain, and this can hasten recovery of the patient. Uncertainty remains still persists about the benefits of NIV in the management of patients with hypoxemic ARF, as despite improvement in oxygen, this NIV may generate high tidal volumes and side which can lead to subsequently ventilator induced lung injury, because we have to realize that it is not possible to give lung control ventilation through NIV because it can always tend to overshoot the requirements and based upon the patient's effort to breathe. NIV improves hypercapnic respiratory failure in acute exacerbation of COPD by improving alveolar ventilation via improved respiratory mechanics, and this will reflect with decrease in the respiratory rate, increase in tidal volume, and increase in minute volume. Thank you very much.